Hello, everyone. Welcome to the Redbud Room, where we'll have today's verbals on sanitation. So if you would, please welcome Virginia Roaf from, University of Leeds. Yeah, so please.
Thank you. It's a real pleasure to be here. Delighted to be presenting my PhD research for the first time in a public forum. As a note, this presentation is not about disciplining people for openly defecating. That would be a violation of human rights. So in my research, I am interrogating academic disciplines to understand how narratives influence how people living in informal settlements access sanitation. And in essence, I'm interested in the reasons for exclusion from access to sanitation, and I'm particularly focusing on the role of local authorities. I'm looking at the following disciplines, so public health, economics or finance, which are not the same things, engineering, social justice, legislation, and planning. The structure of this presentation, I'll just first talk about why I'm talking about disciplines, the method I'm using, which is a Baki framework, and the case study that I'm using to interrogate this, which is in Bulawayo, Zimbabwe. And I'm going to start with some quotes from articles and reports that I'm using in my research. So the first one is, the sanitation economy has the potential to unlock 3.8 trillion litres of new resources generated every year from toilets and sanitation systems. Second one, infrastructural practices affected by the arrangements of pumps, pipes and valves play an important role in elucidating the political and social relations that constitute the city. Third one, if medicine is to achieve its most critical function, it must grapple with political and social life. And the last one, as cities have grown larger and denser, and as the pits and septic tanks have filled up with fecal sludge, practically every large city has begun to feel the need for a sector which until recently didn't even have a name, the fecal sludge management, FSM, sector. So I've just presented a couple of quotes from articles and reports, and the purpose of this presentation is to encourage us to think about how we present a problem and therefore what we propose as a solution. Who is speaking and from what perspective, and why does it matter? There's no judgment, there's no criticism, it's just listening to what people are saying. So to go over those quotes, the first one comes from a paper on the sanitation economy and views sanitation obviously as an opportunity for economic gain. It's from a 2020 report called Poop Scoop. And I think we can agree that's an economic view. The second one clarifies how the state of sanitation is symptomatic of other political and social forces, and this is by a political economist, Nikhil Anand, from 2012. This is a citation from Rudolf Virchow in 1848, commenting on the cholera epidemic of 1947, and he did his best to bring a political understanding to public health, drawing attention to the correlation between ill health and poor living conditions. Public health. And the last one is from a 2018 textbook on environmental health engineering, focusing on the physicality of the problem. And you might say, well, I've unfairly taken these out of context, and some of these texts refer to why it's important to work across disciplines. But they also illustrate how sanitation is often presented in very different ways, and this presentation of the problem affects the possible solutions for improving access to sanitation. So I'm just to say briefly, I've already said, these are the disciplines that I've been examining through the analysis of texts and through interviews with experts, and also in Bulawayo talking to the city council officials. And in the spirit of transparency, I think I should say I'm trained as an architect. I've never practiced, however, so don't blame me for the paucity of women's toilets in public buildings. In advocating for the human rights to water over the years, I've had innumerable conversations, some with many of you, with people from different disciplines, trying to connect on why human rights could advance sanitation. And likewise, during the debates on when we were developing the ideas for the SDGs, it became clear that different actors have different priorities, different approaches, different narratives and understandings of how to improve access to water and sanitation, and obviously for whom. And through the SDGs, the term leave no one behind has entered our lexicon, and I'm convinced that when people say leave no one behind, they really mean it. But what is their starting point? And given their starting point, where are they going to end up? And also, it's in vogue to talk about transdisciplinary approaches. So I've become interested in how that is practiced, particularly within a local authority. So the method I'm using is known as the Bakke framework. Carol Bakke has pioneered the analysis of policies to critique how a problem is defined within a policy and the impact that definition of the problem has on the solution that is proposed. She's also interested in the silences, in what is not said in preparing that policy, and therefore not considered as part as a solution. And just to say, we had a model example, I think, of this yesterday in the plenary, when the moderator defined the problem of access to water as being the unwillingness of individuals to invest in a water utility. And unsurprisingly, the solution eventually led us to the setting aside of the consideration of water as a social good. So I've adapted this approach a little bit to consider reports, articles, and experts define the problem of access to sanitation in informal settlements rather than looking at policies, and how these texts propose resolving the exclusion. And as I say, I'm going to interrogate Bulawayo, Zimbabwe. So this is the City Hall of Bulawayo City Council. This is Zimbabwe's second city. And I wanted to understand how the different departments of that city council discuss sanitation, in particular how they consider the imperative to leave no one behind. What are the narratives from the health, engineering, finance, legal and other departments regarding to access to sanitation by residents of informal settlements? And Bulawayo has a proud history with respect to sanitation, where 95% of the population have either a sewerage connection or a septic tank. And the colonial legacy has left strict bylaws and standards on the types of sanitation that are permitted. And so Bulawayo City Council officials collaborate very well across departments to resolve sticky problems, particularly at times of emergency, such as the recent cholera outbreaks in Zimbabwe. And according to the public health officials that I spoke to, the impetus for improved collaboration was actually COVID, where the Department of Public Health became more important, it gained respect, and it gained more attention. And just to say, I interviewed about 24 officials across these departments, as well as some elected officials and the mayor, to interrogate their understanding of sanitation and of their responsibility towards people who live in the informal settlements, officially less than 5% of the residents of Bulawayo. So who in the city of Bulawayo has been left behind, and why? So there are officially very few informal settlements in Bulawayo, and this is a photograph of one of them, known as Ngozi Mine, which is a landfill site in Bulawayo. It's city council owned and managed, and it's got both legal and illegal waste being dumped there. It's a site of frequent fires, and that is a very dangerous living and working conditions for the waste pickers who work and live there. There's about 150 households living on site. It's estimated there are around 1,000 residents, including children, with no regular access to safe water and absolutely no sanitation, whether it's safe or not. This is an excluded and marginalized population seen by the city officials variously as economic migrants, criminals, sex workers, and delinquents, generally living outside of the norm. So the analysis of interviews with representatives from the different departments at the City Council using this Bakke framework demonstrates the impact that has on decision-making through different narratives, as well as the gaps in the narratives, what is not understood or considered by the local authority officials. And interviewing, I find perhaps unsurprising attitudes towards the residents of the informal settlements. So the public health officials were very clear that everybody needs access to sanitation in order to protect the health of the city. So they were very keen to make sure that there's some form of solution found here. In terms of the social inclusion department, they believe in the humanity of everyone. They work in some ways with the people who live at Ngozi Mine. They know the people, and they try to resolve their social issues. The planners have made several attempts to move people off the site, but they say, well, they keep coming back because there's an economic benefit for them being there, and they kind of shrug their shoulders a bit. In terms of the legal officials, they said that informality is simply illegal and they should not be there. And when I reminded the woman that she'd actually worked a lot in human rights, she said, yes, actually she did know the people there and she'd had previously worked on that settlement. The engineers say that they cannot provide to the standard required by the City Council, so there's nothing that they can do, and anyway they couldn't invest the very minimal resources that are available in the settlement. And the finance people just said, no, we can't possibly invest in short-term solutions here. And so within their own disciplines, these are unsurprisingly results, but it does beg the question, how do we get from here to the sanitation target of the SDGs? And at the beginning of this presentation, I reflected on the call that we've had here for a common narrative on sanitation. And looking at these narratives, I think we're still finding some distance from finding that commonality. If we add to this analysis, as we must, the power and the politics that rest between each of these disciplines, each of these departments, we can acknowledge the difficulties of finding common ground that addresses the issue of universal access to sanitation. And so in essence, and as in conclusion, I believe that we must not only understand each other's language and the way we talk about sanitation, but we also need to do a lot more work to understand each other's values. Thank you.
Questions, and if you would, I'll run the mic to you so everybody can hear it, and our online audience can hear as well too. Yeah, go.
Super interesting presentation. Thank you very much. I was just wondering what your next steps were with the research. Thinking about language and values and disciplines. Where were you going with it?
So that's an excellent question. I'm just going through that process of analyzing the data through using the Baki framework. I mean, I've literally got back from Bulawayo last month, so I've still got a lot of work to do there. But I think that I don't think I'm going to provide a great answer, but what I'm trying to do is move us towards asking more difficult questions. For example, and I'm going to quote you now, Claire, if I may, I think we really have to question how we're going to align the disciplinary narratives that go along with the talk about credit-worthy utilities and the narrative that goes with universal access to sanitation. And I think if we don't start coming closer and really interrogating and finding ways of bridging that gap, I don't see how we're going to reach our goals. Does that answer your question? Thank you.
We can do maybe one more question.
Did you want to ask a question, Sabita? Okay.
So you talked about where the values of the different actors and different disciplines differed. Were there any values that were shared or where there was crossover that might be a good place to start in building those connections between the disciplines?
Well, as I was saying about when I was actually talking to the public health officials about their experience of COVID, there was immediately a greater value placed on the work that the public health officials were doing because they had the skills and the tools that they could use to protect populations from the pandemic. So I think that was an eye-opener for them, that that's not just a cost. Sanitation is not just a cost, it's actually something that benefits. So, you know, you have to try and find the ways of bridging that gap. There are very clearly some synergies. Public health and social justice as actually can fit together very well. The economists and the engineers also understand each other's language. They're trying to deliver something within a time frame, within a and within a time frame and to a particular standard. Having said that, sorry, I had lost the train of my thought. Oh, I was going to say about decision making and the accountability process that belong to different disciplines. Whereas public health officials' timeframes will be very short and immediate, which engineers can respond to very quickly. If there's a cholera outbreak, for example, they need to be able to track that person who's got, and I've got amusing stories about that. But and whereas the engineering timeframe can be a lot longer, and they'll have a master plan that's planned for the next 20 years. So I think there's also something there about understanding how people make decisions and the accountability and how they're held to account for those decisions.
We'll do one more.
I've got the stop.
Sorry, we'll do one more question.
Oh, okay.
Thanks, Virginia, it's me. I'm curious to know why you feel that seeking credit worthiness is incompatible with taking an approach of achieving universal. I mean, to me, a utility wants to become credit worthy in order to attract financing, in order to achieve universal service. Why do you think it's incompatible?
I don't think it's necessarily incompatible, but I think that the way I was really just referring to that particular plenary where the question was asked I don't think it's incompatible. I do think we need to look very much more carefully about where that financing or that funding is coming from. And I think that also we need to just simply recognize that sanitation is not going to be financially viable in the short or even maybe in the long term. I mean, you may have I don't believe that.
I don't think being a utility being credit worthy does not mean that it can't subsidize. I mean, utilities borrow money in order to be able to provide subsidized services to people who need them. So I think we have a...
No, I don't. I
we'll
mean,
talk
I agree.
more.
I agree. I just think that the way that it was talked about in the session yesterday was perhaps not recognizing that. But I agree. I mean, yes, no, they don't need to be separate. But I think that actually the way that people talk about it, they seem very separate. They can be very different narratives. And we need to find ways of bridging that gap so that we have constructive conversations about it. Clarissa. And I've got the mic and you haven't.
All right, thank you, Virginia.
Thank you so much.
All right, please welcome Megan Dorris from the Centers for Disease Control. Wow.
Thanks. Hi, everyone. I'm Megan Dorris, and as you stated, I'm coming from Centers for Disease Control and Prevention. So today we're going to be talking about factors associated with hand hygiene in community settings in Uganda. So setting the stage here, as we know, hand hygiene is a low-cost, effective way to reduce the spread of respiratory diseases like COVID-19, especially in low-resource and low- and middle-income countries. In April of 2020, the World Health Organization released new hand hygiene guidance, expanding on previous guidance and introducing 2 new key moments for hand hygiene. This new guidance recommended universal access to public hand hygiene stations and recommended mandating their use when entering and exiting any public or private commercial building during the COVID-19 pandemic. So to meet new WHO recommendations, CDC and the Infectious Diseases Institute partnered in Uganda to provide hand hygiene stations at entrances, exits, and toilets in community gathering settings such as schools, markets, and places of worship. And also at what we considered health facility adjunct areas. So we defined these as publicly accessible spaces that were non-clinical areas of healthcare facilities. So that might be like the entrances or the outpatient toilets. So in the past, we found that hand hygiene research has often really focused on For example, healthcare workers in clinical settings, children at schools, or on hand hygiene at households. So, for example, previous studies have shown that things like professional category or shift or care area has been associated with different hand hygiene practices. Community gathering settings and health facility adjunct areas have typically been left out of these studies and neglected as priority sites for hand hygiene research. We're lacking evidence on factors associated with hand hygiene research in these diverse settings. So, in our observational study, we hope to fill these gaps by observing hand hygiene in these areas in 2 districts of Uganda. Our goal was to identify factors associated with 1, hand hygiene access or hand hygiene material access, so that's access to things like water and soap or alcohol-based hand rub, and 2, hand hygiene practice. And we chose to explore these factors in community gathering settings and health facility adjunct areas in Uganda. So now moving on to our methods and materials. We conducted our observational study in Amuru and Tororo districts of Uganda beginning in 2021. Observations were collected at a total of 86 community gathering settings and health facility adjunct areas. So we had 43 sites in Amuru and 43 sites in Tororo. Our sites included 22 border points of entry, 8 schools, 11 guest houses, 5 places of worship, 9 markets, 7 police stations/prisons, and 24 health facility adjunct areas. And these sites were identified by CDC, the Infectious Diseases Institute, and local governments as sites that were at high risk of COVID-19 transmission. So our study is a secondary analysis of the evaluation data that was collected during an ongoing intervention with CDC and IDI at the time. At each site, we observed visitors passing hand hygiene stations at 3 key hand hygiene moments: upon entering and upon exiting these community gathering settings or health facility adjunct areas, and after toileting. We recorded these observations at each site for roughly 30 minutes or 20 visitors, whichever came first, from a site that wasn't easily visible by those visitors. For each visitor observed, we recorded hand hygiene station characteristics. So these included the hand hygiene station type, meaning hand wash station, alcohol-based hand rub dispenser, or a combined ABHR dispenser/hand wash station. We also recorded the available hand hygiene materials, so those were recorded as water only, water and soap, ABHR or none, and any behavioral cues that were present at the hand hygiene station. So that could be educational materials like a poster that was there, or a hand hygiene attendant, or none. We also recorded visitor characteristics. So this included the key moment that the visitor passed the hand hygiene station. So again, entering, exiting, or after toileting. The materials that they used. So again, water only, water and soap, ABHR or none. And we estimated the visitor's age. So it was estimated as approximately child, adolescent, or adult. And we recorded the visitor's sex. We collected our observations at 3 time points during the COVID-19 pandemic. And we used the COVID-19 case burden during this time to estimate changing risk perception in Uganda. And our observations were recorded in April 2021, so that was just prior to the peak of the pandemic in Uganda, and so this was perceived to be high risk. In October of 2021, which was post-peak pandemic, so this was perceived as moderate risk. And then observations from August of 2022 were perceived as low risk for COVID-19 transmission. And then we analyzed our observations. In this study, our primary outcomes of interest were 1, hand hygiene material access, which we defined as access to water and soap or alcohol-based hand rub, and 2, hand hygiene practice, which was defined as hand hygiene with water and soap or alcohol-based hand rub. We calculated the frequency and association of these outcomes with hand hygiene station characteristics and visitor characteristics across changing COVID-19 risk perception in community gathering settings and health facility adjunct areas. We used modified Poisson regression modeling to estimate association of hand hygiene material access and hand hygiene practice with our independent variables. And we estimated risk ratios from our model and used 95% confidence intervals and an alpha of 0.05 to determine statistical significance. Now for our results. We observed a total of 2,005 visitors during hand hygiene key moments. 55% of observations were recorded in Chiradzulu District. 48% of observations occurred upon visitors entering, compared to 35% upon exiting and 17% after toileting. Most visitors were adult, and most visitors were male. Most observations were collected in health facility adjunct areas, border points of entry, and markets. And again, we collected our observations at 3 time points. So 33% of observations were collected when the COVID-19 risk perception was high, 27% when COVID-19 risk perception was moderate, and 40% when the COVID-19 risk perception was low. So first, we will focus on hand hygiene material access. We found hand hygiene materials were accessible at 75% of the 2005 key moments that we observed. Access was highest at border points of entry and places of worship. And access was also higher upon entering facilities compared to exiting or after toileting. In the adjusted model, hand hygiene material access was 1.2 times as likely at hand hygiene stations with an attendant present. It was 1.4 times as likely at combined ABHR hand wash stations compared to a hand wash station alone. And 0.7 times as likely, or 30% less likely, when the COVID-19 risk perception was low as compared to COVID-19 risk perception being high. So we just addressed access to hand hygiene materials, so we're going to turn our attention now to hand hygiene practice. Hand hygiene practice occurred in 24% of observations that had access to hand hygiene materials. Practice occurred most frequently during key moments at places of worship and after toileting compared to entering or exiting. In the adjusted model, when compared to health facility adjunct areas, we found hand hygiene practice was over 3.5 times as likely to occur during key moments at places of worship, and over twice as likely to occur during key moments at police stations/prisons, and 1.8 times as likely to occur during key moments at schools, again, all compared to at key moments at health facility adjunct areas. We also found hand hygiene practice was 1.5 times as likely to occur with a hand hygiene attendant present, and 1.3 times as likely to occur at combined ABHR hand wash stations compared to a hand wash station alone. Now, how can we use these findings to improve hand hygiene access and practice? First, hand hygiene practice is not possible without access to water and soap or alcohol-based hand rub. And we saw access to hand hygiene materials varied during the COVID-19 pandemic. We also saw there is room for improvement across all key moments that we observed in our study. Therefore, future hand hygiene strategies should promote consistent access to hand hygiene materials at all sites, so at all community gathering settings and health facility adjunct areas, and promote hand hygiene practice at these new key moments that were referenced by WHO. So upon entering, upon exiting, and after toileting at these settings. Hand hygiene attendants and combined ABHR dispenser hand wash stations may be effective strategies to consider to increase hand hygiene access, or hand hygiene material access, and hand hygiene practice. Hand hygiene attendants may play an active role in hand hygiene station maintenance and act as a behavioral cue to encourage hand hygiene practice. Combined ABHR dispenser hand wash stations have multiple materials, which may mean or require less frequent stocking and appeal to the preferences of more hand hygiene station visitors. But overall, more research is still needed on the cost and effectiveness of these interventions. Next, we saw the likelihood of hand hygiene practice when hand hygiene materials were available was highest at places of worship, police stations, and prisons and schools. So these were locations with relatively stable populations. So future interventions in locations with transient populations, places like markets or guest houses or border points of entry, should prioritize behavior change. While our finding did provide valuable insights for future hand hygiene strategies and research, the study does have limitations. Observation methods tailored to specific locations may better capture the variation in visitors and behaviors at these settings. So for example, observations collected during meal times or on weekends may capture different populations or different behaviors. In conclusion, our study highlights the need to improve hand hygiene material access and hand hygiene practice upon entering, exiting, and after toileting in community gathering settings and health facility adjunct areas. Settings with transient populations should be prioritized for hand hygiene interventions. And hand hygiene attendants and combined ABHR hand wash stations could be effective hand hygiene interventions to consider in these community gathering settings and health facility adjunct areas. Thank you very much.
Hi, I'm curious on your findings with regard to the increased rates of hand washing at places of worship. Are you noticing that that's higher on the before entering the place of worship? I would imagine as perhaps some sort of like cleansing before worship, or is it more evenly higher across the before entry and after leaving?
Sure, so I'll have to go back and double check some of the data on this, but most of our data was upon entering places of worship. So we did try to adjust for this in the model, but it was kind of hard to say because it was so heavy on collecting those observations upon entry that we did see that it was definitely higher at that time point compared to it looked like after toileting upon exiting. But that's a place that we definitely need more data to be able to really determine that answer.
Hi, excuse me. Hi, quick question. I was curious if for the hand washing stations, if you noted if they're facing one direction or the other, and if that affected like when you're entering or exiting, or were they like double-sided hand washing stations?
Yeah, good
Thank
question.
you.
I actually don't have that information, but I can definitely reach out to our team in Uganda and try and get that, but that's a good question to look into for sure.
Thanks, Megan. That was a great presentation. Just one question. In terms of the areas that were a bit more problematic, do you know, which as I recall, it was markets and transport hubs, was there any potential bias in terms of those spaces that are a bit less controlled, perhaps, than the healthcare facilities or places of worship or police stations? So was there any potential bias there? And do you have any insights as to, I mean, more research is necessary, but what are your thoughts on how do we address those areas? Because those are definitely challenges, particularly in outbreak settings. Thank you.
Sure, absolutely. So, I mean, that was kind of one of our discussion questions of, we had this kind of thought of like a consistent authority figure potentially playing a role. So if we're looking at, like you said, the health facility adjunct areas or schools, prisons, we see that maybe there could be a consistent authority figure that's kind of controlling those spaces a little bit more. So that's definitely going to be a challenge for us. We would like to get more observations maybe in those locations would be great. But at this point in this study, we finished collecting observations a while ago. So I would say maybe to focus on those areas in the future, that would be a place where we would try to target these specific, like different styles of observation. So where I mentioned that we could, at markets, maybe gather observations at a wider interval of time so that we're getting more variety in the visitors that are going there and across different times of day. maybe across different seasons, if that's changing anything, that could help give us more information. But at this point, we don't necessarily have that study planned. I don't know if that really answers your question, but.
We could do maybe one more quick question.
Hey, thanks, Megan. That was great. On the combined hand washing and ABHR stations, do you have a sense for the why that might have stood out? I mean, maybe it's people like choices and things like that, or do we have data breaking it down, like were certain types of people, you know, characteristics going and hand washing more than hand hygiene, et cetera? Do we see it break down demographically or anything like that?
I mean, I think that you maybe answered it a little bit in your question. So one of our previous studies that was done in some of these same areas involved collecting more qualitative data. And some of the feedback that was given then was that, especially in places like markets and border points of entry, certain visitors are looking for different things. So if you're coming in with heavily soiled hands, you're looking more for soap and water versus, you know, if you cough or sneeze, maybe you're just looking for something quick. Or if you're in a hurry, you might just reach for the ABHR, that hand rub. And so it probably does appeal to different visitor preferences. And then we also saw, of course, you know, you have to have access to hand hygiene materials in order to practice hand hygiene. And so one thought is just you have multiple materials, maybe these are having to be stocked less frequently. So if we know that, for example, one location, they're only being restocked, you know, once a week or whatever it may be, maybe those combined stations are more likely to actually have materials still available. And so people are more likely to go and practice hand hygiene there.
Thank you, Megan.
Thanks.
All right, please welcome Clara MacLeod from the London School of Hygiene and Tropical Medicine.
Thank you. Good afternoon, everybody. My name is Clara MacLeod. I'm from the London School of Hygiene and Tropical Medicine. And today I'll be presenting on a case study looking at the impact of a climate-related disaster on household sanitation access in rural Chiradzulu District in Malawi, pre and post-Cyclone Freddy. And I'm presenting on behalf of our research partner MUBAS in Blantyre, Malawi, and our implementing partners World Vision and Water for People. So first, for some background, I think as many of us know, extreme weather events such as droughts and floods are expected to increase in frequency and intensity over the next decade. And these extreme weather events pose a significant threat to essential infrastructure, public health, and livelihoods. And as you can see on the right, these are some pictures from Cyclone Freddy, and this just shows the extent of the damage to essential infrastructure, as well as all of the flooding that occurred because of the cyclone. And while we know that floods do impact sanitation, there's very limited evidence that actually quantifies the impact of flooding on sanitation infrastructure, services, and practices. And this case study is set within a district-wide sanitation program in rural Malawi, which caused widespread damage to the area and specifically on sanitation infrastructure. And the aim of this case study was to compare household sanitation access pre and post-cyclone Freddy using routine monitoring data from a community-led total sanitation program in rural Malawi. And this was very kindly done by World Vision, who shared all of the data. The specific objectives of this case study were to quantify the impact of the cyclone on household sanitation infrastructure in a program area that had previously achieved open defecation-free status. And then second, to actually understand the short-term household sanitation reconstruction efforts and decisions 3 months post-cyclone. And below is just a very brief graphic representing the aim and objectives. So now moving on to some context. So traditional authority Lekoswe in Chiradzulu District, Malawi, And Chiradzulu District is one of 28 districts in Malawi, and it's located in the southern region of the country, as you can see on the figure on the left. And the district is subdivided into 10 administrative regions, or traditional authorities, or TAs. And TA is one of the traditional authorities in Chiradzulu District, and it's located on the western edge, as you can see on the figure on the right. It's composed of 142 villages and has a population of approximately 76,000. And historically, the TA has had limited access to improved household sanitation. In terms of context for the program, so this case study was set within the Water, Sanitation, and Hygiene for Everyone program, which is a district-wide sanitation or WASH program in rural Malawi. And it aims to expand water, sanitation, and hygiene services in the entire district of Chiradzulu. And it's implemented by World Vision and Water for People. In terms of sanitation, community-led total sanitation is a key component, primarily delivered by World Vision. And CLTS was delivered in line with the CLTS handbook developed by Carr & Chambers in 2009. And very briefly, CLTS relies on behavior change and community self-enforcement to end open defecation in rural areas, and has 3 main activities. As you can see on the right, pre-triggering, triggering, and follow-up. In terms of a timeline of events, so World Vision started implementing CLTS activities in 2022, but before program activities started, they conducted a program baseline survey of all household wash facilities and practices. And then later that year, in December 2022, TA Lekoswe was declared open defecation free by the government of Malawi, and this signifies universal access to sanitation in the TA, and this could be either improved or unimproved sanitation. Several months later, in March 2023, Cyclone Freddy hit Chiradzulu District, and it was the longest and most powerful tropical cyclone in the region. And again, it caused widespread damage to households, including sanitation infrastructure. And then roughly a year after the baseline survey, World Vision conducted a follow-up survey, so very similar to the baseline survey, and again collected information on household wash facilities and practices. So in terms of methods, data was collected via the household survey at program baseline and one-year follow-up, using routine monitoring and evaluation data from World Vision. And we included 311 households in this case study, which were linked via a unique household ID at program baseline and follow-up. And at the follow-up survey, additional questions related to Cyclone Freddy were added to the questionnaire. Household sanitation definitions were in line with standard JMP definitions, and we used all of this to first estimate the number of sanitation facilities that collapsed due to Cyclone Freddy, and then second, we compared sanitation access pre- and post-cyclone for each household included in this case study. So a quick snapshot of sanitation shortly before Cyclone Freddy. So among the 311 households that we surveyed, 92% had at least unimproved sanitation, 3% had limited, and 5% had basic. So again, a big majority of the population had unimproved sanitation. And I won't go into all of the calculations right now just for the sake of time, but we combined program baseline data and ODF verification data to arrive at these estimates. Now this is a Sankey diagram, or a flow diagram, which shows flows of participants or data from one state to another. And this flow diagram has 3 states. So the first is household sanitation access pre-cyclone. The second is whether the latrine collapsed or did not collapse. And then the third is household sanitation access 3 months post-cyclone. So if you focus on the left side of the diagram, again, you can see 5% of households had access to basic sanitation, 3% to limited, and 92% to unimproved. And then if we follow the flows, we can see that 68% of latrines collapsed and 32% did not. And then if we follow that again even further, we can see that 3 months post-cyclone, 6% of households had access to basic sanitation, 8% to limited, 50% unimproved, and 36% had no sanitation facilities. And I just want to highlight that this is a snapshot of sanitation access 3 months post-cyclone. After the cyclone, implementing partners worked really hard, and several months later, Tiela Koswe was actually again declared open defecation free. But again, just a snapshot, and interesting to see sort of what happens in the immediate aftermath. And if we focus on this bottom right quadrant of the latrines that collapsed, if we link this back to the diagram that I presented in one of the earlier slides, we can actually see that almost a quarter of surveyed household sanitation facilities collapsed due to Cyclone Freddy. And again, this is a huge amount of households. So this is 211 in total. And we can also see 3 months post-cyclone, over half of households did not have a sanitation facility, or by that time were not able to reconstruct a sanitation facility. We can also see that of the 211 of the households that did reconstruct, most reconstructed an unimproved sanitation facility, and this is at 43%. And we can also see that less than 5% of affected households rebuilt an improved sanitation facility. And in terms of what these results mean, the results highlight the impact of Cyclone Freddy on household sanitation access, especially in an area that had really high sanitation coverage, especially due to CLTS. The results also provide a snapshot and insights into immediate household sanitation reconstruction efforts and decisions. We don't have the qualitative data to support it, but we can see sort of at the community level what household efforts happened. And we also see that because of the latrines that were reconstructed, which were mostly unimproved, they may still be vulnerable to future extreme weather events, especially in southern Malawi, which is prone to cyclones. And the final point is that climate vulnerable sanitation limits the sustainability and economic benefits of interventions that focus on unimproved sanitation coverage. And that's it. Thank you.
Thank you very much. It was very interesting. It was a very interesting presentation. I'm really sorry. I'm going to use my privilege as the first person to ask 2 questions. My first question was, it was very interesting to see that basic sanitation access actually went up by 1% post-cyclone, from 5 to 6%.
Yeah.
So if you could tell us what happened there, I'd be very interested to know. My second question is, could you tell us a bit more about how the triggering interacted with the rebuilding of facilities? In my experience and in my work, behavior change programming is severely affected with the damage and collapse of latrines, and people get really fatigued. And in that sense, then, behavior change programming starts to feel a lot more punitive even in those circumstances. So could you tell us how the CLTS program then interacted with the rebuilding?
So for your first question, which was why basic sanitation went up, we have a few anecdotes that suggest that some households wanted to build more resilient climate or sanitation infrastructure. So we don't have any sort of qualitative data to support that, but I think that might be a possible reason why. And then for your second question on triggering post-climate or post-disaster, World Vision didn't necessarily go back and implement CLTS exactly as before. I think they're more on the ground to just support households sort of in this emergency response context. So yeah, I don't know specifically how those interacted. But yeah, we can follow up after. We have some people who worked on the program as well. Thank you.
Thank you for the presentation. I just wanted to know whether after the disaster, whether the approach was different in terms of recommending options that would be more resilient, because then the CLTS type of toilets could have been, the kind of what we recommend, the locally available materials. But after the disaster, did that change the way things were done?
Yeah, good question, thank you. Yeah, there's a big focus on durable materials, so it's a big part of the response as well. So it's not necessarily focusing so much on moving from unimproved to improved, but focusing more on durable materials for the reconstruction of the sanitation facility.
Do you have any data points? Are you likely to have data points like after the post-cyclone reconstruction, so you could somehow look at a curve of destruction and rebuilding and see how that trajectory continues over time?
Yeah, I think we could definitely look at that. Another thing that we discussed is actually doing some sort of spatial analysis, because there is some GPS information. So the cyclone was stronger in some areas versus others, and that's why some of the latrines may not have collapsed, so we might do that. But yeah, I think some sort of curve, as you suggest as well, would be really interesting to look at. So we just got the results like 2 weeks ago. So yeah, interested in more thoughts about how we can present the data or other ways to explore the data as well.
We can do one more quick question.
So that's really, I think you kind of half actually just answered with the fact that you just got this data, because I'd be really curious how this would change at 6 months. Because I imagine right after a disaster like this, materials are really hard to come by, and the whole supply chain is, at this point, probably pretty messed up. So I am kind of curious, what would you expect the 6 months results to be based off of what you know of the operations that are continuing to happen on the ground? And if it is like a matter of maybe the supply chain, or if it's actually like financials of rebuilding, or even demand, as people have moved past to having no facility or an unimproved facility, still feeling like they have access to something, are they demanding to have better access to better toilets, or is it just like there's other priorities at bay with everything that, reconstructing a whole lifestyle again? Thank you.
Good question, thank you. Yeah, what we saw, so actually a couple of months later, the TA was declared open defecation free again. I don't remember exactly what the timeline was, but it was not too long after that. So yeah, what was interesting with if you look at the 36% with no facility, that meant just at that point in time, at 3 months, but households could have also been reconstructing at that time point. So maybe a couple of weeks later, that number of no facilities could have changed. Households are definitely really interested in rebuilding, and a lot of it was with more sustainable or durable materials. But what we did see from some anecdotes and a little bit in the data is that finance or access or the cost of rebuilding was also very expensive. So I think partially answers your question.
All right, thank you, Clara.
Thank you.
All right, please welcome Sabita Adhikari from the University of Sydney.
Okay, of course. Hi everyone, thank you for being in my presentation. My name is Sabita Adhikari, and I'm a PhD candidate at University of Sydney. So I'm presenting today on investigating fecal contamination level on household latrine surfaces in rural contexts of Fiji and Nepal. So talking about the global sanitation challenge, we know that unsafe sanitation is a risk factor for transmission of several infectious diseases like diarrhea and typhoid, and it particularly affects the vulnerable communities, and especially women and children and other marginalized community in lower and middle income countries. And as we all know, like SDG 6, particularly 6.2, has targets to solve it as equitable and adequate sanitation for all. And we also have different sanitation service ladders, where our aim is to at least reach basic sanitation and also target to reach safely managed sanitation, which both are considered as like improved sanitation infrastructure. So talking about the rural context, we know that sanitation, on-site sanitation is used in a lot of rural areas in lower and middle income countries, and my research is more on the user interface or the front end of the sanitation value chain. So in terms of the previous research, for example, in terms of Pacific and Fiji, we see a lot of research that has been done in terms of the microbial contamination that goes through the back end, either through the contaminated surface or the groundwater, or through the leaching or the flooding of the unsafe containment system, or through the consumption of the unwashed vegetable or produces. However, the microbiological data on the user interface is not much in the literature. The data is really limited. And particularly, we do have some data on the public latrine, but the data on the household latrine is really limited. And I did a review and found that there was like there was around 10 studies that particularly measured the microbial contamination in the latrine surfaces, in the household surfaces. So there's really a data gap on this side. So the objective of my this presentation and the study today is to see the to assess the fecal contamination level, and we use the fecal indicative bacteria E. coli on the surfaces of the rural household in Fiji and Nepal, and try to see what are the common patterns in these two different distinct contexts. So as I told already, the case study location side, it's the Pacific, where the sanitation data is really limited in Fiji, and the South Asian context of Nepal. Just giving a brief background of the Fiji, there's a lot of collaborator here, and I'm presenting here. So this part of the Fiji was part of the big project called Watershed Intervention for System Strengthening, System Health, as WISH Fiji. So it was a big planetary health approach project which had its aim to reduce typhoid, leptospirosis, and dengue in Fiji, and it had a lot of other watershed intervention where water sanitation and hygiene was one of them. And it was funded by DFAT for Australian government and also Bloomberg Philanthropies. We also had Fijian National University as our collaborator there, and other several universities and WCS from Fiji itself. So it's a very, the results I'm presenting is a very small part of a large project there. So in terms of the access, the recent JMP shows that Fiji has done a good job in terms of access to the improved sanitation infrastructure. It's at over 90%. And however, it still battles with the fecal oral disease like typhoid. It's endemic there. So in terms of the project, the catchments covered there, this project WISH Fiji covered 29 communities across 5 catchments in 3 main islands. And in terms of the in-depth latrine sampling, I conducted in 1 community in 1 catchment. So just to give you a context about what kind of latrines are there in Fiji, so we surveyed like around 311 households. I'm not presenting the data here, but over 90% has the cistern plus pedestal, which is normal Western type of toilets. There were also like 10% of the pour flush latrine where there is a manual flushing with the buckets. And there are also like the non-flush latrine where there is a hole directly connected to the pit underneath, which is like a dry toilet. So these all are the pedestal kind of toilets there. And in terms of like behavior of people using it, or in terms of the anal cleansing method, toilet paper is very common there. And also paper-based, meaning that both toilet paper and newspaper are also used in the rural areas. So for a person who grew up in Nepal, it was really interesting for me to see all this infrastructure because it was very different back home. So that's where the second case study comes from in Nepal. Nepal has also done a pretty good job with the access. The recent JMP also shows that Nepal is on track to have at least basic sanitation. But we do also have the endemic fecal oral diseases like cholera and typhoid, and it recurs every year in Nepal as well. So in terms of the case study side, it was done in Chitwan district, which is in a rural municipality called Ichakamana, which is around 110 kilometers away from the capital, Kathmandu. So just to give again the background of the types of latrine in Nepal, especially in the user interface side, we heavily rely on the pour flush squat latrines there, which is quite different. And it's common in a lot of South Asian countries as well. We do also have some non-flush dry latrines, but it's more like a VIP, like a ventilated improved latrines. Few households these days, which have been newly constructed, have been starting to now have a cistern flush pedestal kind of latrine as well. But in terms of the anal cleansing behavior, we heavily rely on the water-based anal cleansing. We don't use toilet paper at all. And it also relates to a lot of socio-cultural concept we do have behind it. So in terms of the method that we used, so I did the household and sanitation survey to understand how about different like demographics and the latrine users behavior. I also did the sanitation observation to see like how the latrines have been maintained. And then I did the microbiological sampling for the E. coli in different surfaces. And yes, I did all the sampling inside the toilets. It was quite interesting. So going more into the details of the latrine swab data collection, so I collected the swab. So in Fiji, I collected the sampling, I collected sample from 12 household latrines, and it included all latrine types. And it was collected mostly from the frequent contact surfaces. Just imagine where we go into the toilet, what are the different surfaces that we are likely to touch or are in contact with. So considering like the surfaces, they were different in different infrastructures as well. This is from Nepal. And I did my sampling in Nepal in 8 household latrines, and it included both cistern and pore flush. And I also took the water sample in Nepal because it was interesting because water samples were not in Fiji, because in Nepal we do have water stored in a bucket for flushing as well as the anal cleansing as well. So I used the portable WalkTech kit and measured E. coli using the membrane filtration method by counting the colonies. So in terms of the results in Fiji, as expected, latrine floor had a high frequency of positive E. coli sample, followed by the mid-wall and latrine seats. In terms of the concentration, which is on the y-axis, is colony forming units per area swabbed. Latrine floor had the higher concentration of the density, around 10 to the power 3, and it was also followed by latrine seat and then the mid walls. So in terms of the Nepal study, as expected, squat plate had higher concentration, had higher frequency of positive E. coli sample, and what was really interesting is the deeper handle, meaning that that blue thing over there, the mug or the pitcher that is used to scoop in the water to clean and to flush the latrine, had 100% frequency of positive E. coli samples. And in terms of the concentration, it was consistent that squat plate had higher concentration, and then followed by the latrine floors and deeper handle and other surfaces. So it was interesting, and but not surprising for me, like the anal cleansing water, or the water in the bucket that was stored in the bucket, had significantly higher E. coli compared to the tap water where the source of water was. So it shows that there is a lot of cross-contamination or the unsafe handling of that water. And I just wanted to share this, link it with my personal experience, because there is an experience behind every data. So it's growing up in Nepal. When I was about 10 years old, my parents built a new house. So we shifted to the new house. Everything was new. We had new kitchen utensils. We had like new toilets, one inside the house and the other outside the house. But then I still remember that the bucket that we use in the toilets were the bucket that were used in the construction of the house. So it was kind of like very hard to clean, because it had a lot of paint in it. It had a lot of cement in it, you know, like the buckets that couldn't used anywhere in the house end up in the toilets. A lot of things have changed, but also a lot of things hasn't changed in terms of our perception on prioritizing these things. This is a picture I took on February when I was in field work around the same area. So there was this household who was building this new house, new toilets. All the new toilet building was new, the toilets was new. But if we see the buckets and the deeper over there, the scenario hasn't changed much. So I really want to focus on like this anal cleansing hardware. So overall cleaning of the surfaces on the latrines has been highly overlooked and neglected aspect of the sanitation and hygiene. And when we go back into the literature, we don't see a lot of these latrine users' behavior, especially the anal cleansing methods, being incorporated in our intervention or also in our research. So this is also a risk for the urinary tract infection, particularly for the women, if we have a lot of E. coli contamination in the water, because this is the same water that's been used to clean ourselves, especially during the menstruation or in a day-to-day basis. And it is a potential transmission pathway for urinary tract infection if it's already contaminated with so much of E. coli. And it's not relevant only in Nepal. I think it's relevant in a lot of countries where water-based anal cleansing is common. So it's not an isolated case. And this has to be stressed in our sanitation and hygiene interventions. To talk about the common pattern observed in rural Fiji and Nepal, so we saw the significantly higher E. coli on the latrine floor and the squat plate, which both are at the floor areas. And pore flush latrine had significantly higher concentration compared to the cistern flush latrine. But I should note that our sample size is quite small, and I think we really need to have further research on to validate these relationship. But the reason behind in Fiji was the Fiji had a lot of infrastructural failure. So the house has like a good cistern flush toilet in the beginning, but after sometimes the cistern breaks, the pipes breaks, and people don't, the household didn't maintain the toilets, and there was a lot of leakage on the floor, and also a lot of dirt in the floor. While as in Nepal, it's kind of hard to have a dry floor because we use like water-based anal cleansing, and it's pretty easy for the floor to be wet. And we also found that the surfaces with visible moisture and dirt had higher E. coli density compared to the dry and clean surfaces. And with this, I really want to focus that all the samples that I took on the latrines were, if we consider the infrastructural criteria, they are in improved sanitation. They are even in the safely managed sanitation criteria. But I think as a sector, we really need to rigorously pay the attention on latrine cleanliness, disinfection, and the safe use, and which I think has been the core idea of the whole conference, that it's not only about infrastructure. We have to consider this different latrine users' behavior as well. So coming to conclude, so this study is the first to assess the contamination level in rural Fiji and also in rural Nepal. So it also fills the data gap for the microbial risk assessment. Pathogen, like the density of the microorganism is one of the biggest limited data in terms of QMRA. So it's a small step to fill up that data gap as well. And it also really brings it to the attention of this neglected anal cleansing method to be incorporated in our sanitation and hygiene intervention and also in our research. And again, at the end, just to ending up to like shift our focus from access to the infrastructure to maintenance and cleanliness. And I hope this way we can build our household safe, community safe, with one clean latrine at a time. Thank you all. Any questions?
Hi, that was really interesting and really great. I'd be really interested to hear about the contamination that you found on the floor and how much of that you reckon is due to the flush activity and it being level with the floor, and how much is to do with the cleansing practices and how they might interact with each other.
Yeah, that's a good question. Thank you. Yeah, it's just like it would be really interesting if I had the resources to do the microbial source tracking and see where the E. coli were from, because I really looked only into the fecal indicative bacteria, so I don't know the source. But and I think like there's a lot of research that has shown that the aerosolization from the flush also contaminates the floor. And I think in terms of Nepal, it's really easy to get contamination during the anal cleansing process because we squat there, and then it's very easy to get cross-contamination also because the water we've been using, it's already contaminated. So it's very hard for me to right now to quantify how much is it from these different aspects, but I think further research would really, and there have been good research, if we have source and the logistic and the resources, it would be really good to see and track the source of where the E. coli is from. But I really can't quantify right now how much is it from the flush aerosol or how much is it from, even from the soil, which is already there, because E. coli can also be inherited in the soil as well. Yeah.
It's a really great presentation. I'm just wondering who your target audience is, because a lot of the presentations that we've heard here are aimed at policymakers and politicians, whereas your message really resonates with householders and consumers.
Yeah.
So how are you going to get your message across from an academic perspective, where your target audience would normally be policymakers and other academics? How are you going to get your message out to householders? Because the behaviour change would be really key.
Yeah, thank you for the question. In Fiji, we have a lot of local collaborators over there. And this project I have been involved in Fiji has now also the second phase, and it's extended to all the Pacific areas like Papua New Guinea, Kiribati as well. So we had done a dissemination project, and we are trying to, we did work with the community health workers over there. So we are trying to put the message with them so that they are the frontliners who will spread this message. And we're also working with the stakeholders in Fiji. In terms of Nepal, in terms of the municipality, it was a municipality that I worked before, so I had a good rapport with the local government over there. And I feel like as a practitioner, like I have been involved in WASH in Nepal for like since 2012 when I was an undergrad, and we trained a lot of people when I was working as a practitioner in Nepal. Like we collaborated with the local organization, we collaborated with the health facilities people, and we did train, like said this message about clean latrines and everything. But I do feel like I think we need to have interventions that are more granular, that are more specific. Like maybe like when we said like we need to have a clean latrine, it only translated to have a clean latrine bowl or the squat pan. We didn't have the granularity in our message to say that the anal cleansing hardware should be clean as well. So I think I'm going back home in December, and I'm working with my dissemination of my research with the local government over there, and I really want to train the in Nepal, we have like FCSBs, who are like the female community health worker, and they have really good access to the rural communities. So I'm going to have my research dissemination with them, and I'm also thinking to disseminate this research in that municipality, in the local radios and newspaper, where the people can take it from paper to practice as well. Yeah.
Thanks for the presentation. That was really striking to see the results on the contamination of the anal cleansing material. So I'm just curious, if from what you've seen in Nepal or perhaps other places, are there any? What would you recommend as a solution? Is it something where users should be improving their practices in terms of how they use it and clean it, or have you seen other setups that might offer improved safety for that practice?
Yeah. Okay, so I think like, again, when I was conducting this research, I was kind of like aware that these are very different contexts in Fiji and Nepal. And I was also aware about the cultural sensitivity. So in Nepal, if I go and say like, you can't use water, you need to use toilet paper because this is bad, it's not going to work, because we have a lot of contextual and cultural connectedness with water, cleaning with water. But I do think like the interventions can be thought on, like where are the points where we can put the intervention, where are the barriers we can put the interventions. So it's clear that it's not only a problem in Nepal. I think if we see a lot of South Asian country, or maybe in Africa where there are water-based anal cleansing happening, I think even if we go and see the research, we don't see a lot of consideration of anal cleansing behavior in our research itself. So I think it's a good point for us to stress on that, and like making the hygiene intervention like more granular and rigorously like we can have the messages in the healthcare facilities that we have. I think our intervention really need to rigorous focus on the cleanliness and things. So these are like small interventions we can complement in the existing interventions with the healthcare facility. Maybe in the schools we can teach the kids about all these things. That would really help.
We'll do one last question.
Thanks so much for a great presentation. It's a bit of a follow-up question to this one. And firstly, I don't think anyone should be moving from using water to wiping. I mean, if you want to talk about hygiene. But I did have a question then. Is there already research done on the risk of using fecal contaminated water for UTIs? For causing UTIs or equivalents? Thanks.
the research is really limited on that. I did find like, I think 2 studies that has looked into like if there is any association of different latrine types to have a UTI. And a lot of studies on UTI are commonly on like wiping from front to back or back to front. I don't want to go into details now, but I think it would be really interesting to see like what is because the sample size here is really limited, and it would be really interesting to see if like capturing all these different confounding factors and trying to like control all this and doing some adjusted analysis to see like if the fecal contamination in this annual cleansing water had a causal relationship with the UTI would be a really good research to do. Yeah. Thank you.
Thank you, Sabita. Thanks, everyone. That's all we have for our verbal session, so please enjoy the posters outside. Great job. Oh, I can do that? Yeah, sure, we can do that. Hey, sorry.